for being here today. It's always humbling to give a lecture after the ASN, and I would say operationally difficult, since I didn't have as much time to practice as I would have liked. But I will do my best, and I hope you find something in it that's worthwhile. So first, disclosures. I was site PI of the EMPA study. I did utilize AI for one part of my talk, and these slides will be marked by made by Gamma in the lower right. And the other thing is I've been a nephrologist for over 25 years, and I, like many in nephrology, have been starved for innovation, something new we can do to slow the progression of CKD. So I am predisposed to favor SGLT2 inhibitor use and extol their benefits. And this graph from one of the plenary sessions of the ASN shows that from 1990 to 2024, nephrology was dead last in the number of randomized controlled clinical trials. Hopefully, with the change in endpoints accepted by the FDA and the recent slew of successful clinical trials, this will change in the near future. So first, we'll start with the history. And this goes back to the 1960s when a biochemist by the name of Dr. Robert Crane set forth the hypothesis that sodium and glucose are transported together by a single protein in the intestine. Now, interestingly, Dr. Robert Cade, the first nephrology division chief at UF, and colleagues heard one of Dr. Crane's presentation at a society meeting in the summer of 1965. And that's why they added glucose to what we now know as Gatorade. They added the glucose to speed the uptake of sodium in the GI tract. And they needed the sodium absorbed quickly to replace the relatively large amount of sodium that was measured, that was lost in the sweat of the football players in the Florida Heat. Of course, we all know that Gatorade was credited with UF beating LSU 14-7 on September 24th, 1965, and this is the 60th anniversary of Gatorade. And it's credited by helping the Gators perform well in the second half of the game in the sweltering Florida Heat. So in 1987, to understand how the carrier protein functioned and to understand the origin of congenital glucose-galactose malabsorption syndrome, Hettinger and colleagues cloned the intestinal sodium glucose transporter by expression cloning. Now, at the time that when the cDNA for the protein was cloned, investigators knew there had to be more than one sodium glucose transporter, since previously investigators found that in familial renal glucosuria, where patients had impaired glucose absorption in the kidney, but not in the intestine. And in addition, SGLT1 from the rabbit had the kinetic characteristics of the high affinity transporter. But other researchers demonstrated that the rabbit renal proximal tubule brush border membranes also had a low affinity sodium glucose transporter. So for this reason, Wells pushed to clone the other kidney sodium glucose transporter. And using a low stringency screen of a human kidney library, using the human intestinal sodium glucose cotransporter SGLT1 as a probe, they isolated a 2,271 nucleotide cDNA. The protein encoded by this cDNA was 59% identical at the amino acid level to SGLT1 and had similar number and arrangement to predicted membrane spanning regions. Northern blot analysis demonstrated strong expression in the kidney, as you would expect, but unlike SGLT1, had no significant expression in the intestine. Now, interestingly, you'll see that there might be a hint of expression in the heart, which will become which will become relevant later on. So SGLT1 and SGLT2 are proteins found on the cell surface of the tubules, SGLT2 is a high capacity, low affinity glucose transporter and is found earlier in the proximal tubule in the S1, S2 segments, while SGLT1 is a low capacity, high affinity glucose transporter. It has about twice the affinity for glucose as SGLT2 has, and is found in the later segments, the S2, S3 segments. Thus, all filtered glucose first comes in contact with SGLT2 and then encounters SGLT1. SGLT2 is responsible for 90% of the total glucose absorption in the proximal tubule in the diabetic state, while SGLT1 is responsible for the remaining 10%. But in the healthy state, 97% of glucose is transported by SGLT2, and in the presence of SGLT2 inhibitors, all the glucose transported in the proximal tubule is performed by SGLT1. What's interesting is that SGLT2 expression isn't static. In fact, SGLT2 is increased at the RNA level and at the protein level in type 2 diabetes. This is a kidney biopsy of a relatively healthy. They biopsied the kidney. And this is the kidney biopsy from a diabetic patient. And this is immunohistochemically stained for SGLT2. And you can see the level of brown, meaning the expression of SGLT2, is markedly increased in the diabetic state. What this means that is, if you have diabetes, you transport more glucose, and the renal threshold for glucose excretion is increased. So the renal threshold for glucose excretion goes from about 180 milligrams per deciliter in someone without diabetes to up to 240 milligrams per deciliter in someone with diabetes. So why did SGLTs quickly become a target for the treatment of diabetes? Well, in 1927, the first genetic variant in what we now know to be the SGLT2 DNA was described. And the disorder, familial renal glucosuria, was considered a benign variant. In this disorder, you have, as you would expect, polyuria and polydipsia, and they do have some recurrent urinary infections, as we see with SGLT2 inhibitors, but there are no serious infections. And more importantly, their kidney function is not impaired even after years of living with the disorder. So why target SGLT2 rather than SGLT1? Well, there were a number of reasons to think that SGLT2 would be a better target. One of the reasons was that SGLT1 is found in multiple organs, whereas SGLT2 is found predominantly only in the kidney. So the thinking was that this would minimize potential off-target effects. Second, there already was an inhibitor of SGLT2, fluorescein. And fluorescein was previously been shown to lower blood glucose without increasing insulin. So the thought would be the risk of hypoglycemia would be less. In addition, once you have one inhibitor, it's easier to design other inhibitors. So fluorescein was actually isolated way back in 1885 from the apple tree. And it was originally thought to be useful as an antipyretic agent, useful in the treatment of malaria, but it was subsequently shown to increase urinary glucose. Now, fluorescein is a beta glycoside comprised of two aromatic rings connected to a glucose. The two aromatic rings have an alkyl spacer here. And now an aglycon is the compound left after losing the sugar moiety. And Floretin, is the aglycon of fluorescein. And it's produced when the intestinal beta-glucosidase hydrolyzes fluorescein into fluoretin and glucose. So the concern with using fluorescein as an inhibitor was that the A-glycan fluoretin had some off-target effects, and it could inhibit GLUT1. So the search was on to develop a SGLT2 inhibitor. You wanted a specific SGLT2 inhibitor that would not inhibit SGLT1, and you wanted an SGLT2 inhibitor whose A-glycan wouldn't have activity. So sergliflozin was a prodrug whose active form, sergliflozin A, is a selective SGLT2 inhibitor. Neither it or its A-glycan affected GLUT1 activity. And while sergliflozin did work, but because the A-glycan form did not have biologic activity, sergliflozin A had a short half-life, and thus you needed to be frequently dosed, and thus the drug didn't make it to market. So a lot of investigators, rather than concentrate on the A-glycan, they said, hey, why don't we just develop an inhibitor that wasn't a substrate for the intestinal beta glucosidase? And thus they wouldn't have to worry about the A-glycan at all. And so they did this by creating a compound that was a C glycoside instead of a CO glycoside. And so all of the SGLT2 inhibitors you have heard about are C glycosides, from dapagliflozin, canagliflozin, empagliflozin, and bexigliflozin. So before we discuss the clinical trials, I just want to go over an interesting development that occurred in 2008 regarding diabetic medications. And rosiglitazone was approved by the FDA way back in 1999, but meta-analysis published in the mid-2000s suggested an increased risk of myocardial infarction and cardiovascular death with rosiglitazone. Because of this, in 2008, the FDA mandated that going forward, all diabetic medications had to undergo testing for cardiovascular outcomes. So now the early diabetic clinical trials, and you see the gamma signals. So this was AI generated. In 2010, a study published in Diabetic Care reported that dapagliflozin significantly reduced hemoglobin A1C compared to placebo and did not increase hypoglycemic risk when used as monotherapy. In 2011, they confirmed that dapagliflozin was non-inferior to glipizide in glycemic control, with added benefits of weight loss and fewer hypoglycemic episodes. And in 2015, the EMPA-REG outcome trial showed a 14% relative risk reduction in major adverse cardiovascular events with empagliflozin in patients with type 2 diabetes and established cardiovascular disease. Now, EMPA-REG was the first clinical trial of a diabetic drug that looked at MACE outcomes as required by the FDA. So this is just another point of uniqueness of these SGLT2 inhibitors. SGLT2 inhibitors were shown to effectively control hyperglycemia in type 1 diabetes, but there was this increased risk of diabetic ketoacidosis. So the FDA rejected market authorization for the SGLT2 inhibitors in type 1 diabetes. However, the European Medicines Agency, sort of the equivalent of the FDA for Europe, approved certain SGLT2 inhibitors for restricted use in type 1 diabetes. And they restricted low-dose dapagliflozin 10 milligrams for use with those with a higher BMI. And they specified the higher BMI since those diabetic patients with higher BMI are less likely to have DKA. Then came the heart failure studies. DAPA heart failure demonstrated dapagliflozin reduced heart failure hospitalizations and cardiovascular death in those patients with heart failure and reduced ejection fraction. This was regardless of diabetic status. And then the Emperor studies came in that showed benefits in both heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. And a meta-analysis demonstrated that the benefits in this heart failure patients occurred relatively early, within 26 days. Then, of course, came the kidney outcome studies. There was Credence. The Credence trial was the first dedicated renal outcome study for an SGLT2 inhibitor, and it enrolled over 4,400 patients with type 2 diabetes and CKD, and it demonstrated that canagliflozin significantly reduced the risk of end-stage kidney disease, doubling serum creatinine, and reduced renal cardiovascular death by 30%. The DAPA-CKD study was published in 2020, and it enrolled over 4,300 patients with CKD with or without type 2 diabetes. And this trial was historic in showing dapagliflozin's effectiveness in slowing CKD progression and reducing the risk of renal or cardiovascular death by 39%, regardless of diabetes status. Then came the EMPA kidney study, which enrolled over 6,600 patients, those with a wide variety of CKD, many without diabetes, and lower estimated GFR rates, and empagliflozin significantly reduced the risk of kidney disease progression with cardiovascular death by 28%. This further solidified the role of SGLT2 inhibitors for the use in slowing progression of CKD from all causes. So that's the trial. So let's talk about the mechanism of action. And we'll start with what they're designed to do, that is, inhibit SGLT2. And so by blocking SGLT2, you lead to the loss of glucose in the urine. And this loss is substantial, up to almost 70 grams a day, or 1/3 a mole, or 270 calories, is lost every day in those with normal kidney function. As renal function declines, as you would expect, the amount of glucose is reduced to less than 15 grams a day in those with an estimated GFR less than 30. But with this sodium, you are losing glucose. And in the diabetic nephron, you have increased glucose filtration, which results in increased sodium and glucose reabsorption via the SGLT2. And as I showed earlier, SGLT2 is upregulated in diabetes, which would result in a decreased sodium delivery to the macula densa. With less sodium delivery, you have less sodium delivered to the macula densa, and with less sodium delivered to the macula densa, you have less ATP release. And this is actually an observation made by Dr. Darwin Bell, who was at UAB and a number of other institutions, but who always presented at the Southern Salt Water Meeting, and that will be occurring in a couple of weeks. So it's really some great science is presented there. With less ATP release, you have less adenosine, and then you have afferent arterial vasodilation, which would increase the intraglomerular pressure. With inhibition of the SGLT2 inhibitor, you have less sodium and glucose absorption via SGLT2 in the proximal tubule. That means there's going to be more luminal sodium chloride delivery to the macula densa. That means there's going to be an increase in ATP release, more adenosine being formed, and more effective afferent arterial vasoconstriction, decreasing the intraglomerular pressure. And so this may explain the benefits to the kidney, but does it fully explain the cardiovascular benefits? And so let's discuss some other potential mechanisms of action and downstream consequences of SGLT2 inhibitors. So Billing and colleagues took two approaches to look at the effects of SGLT2 inhibition. First, they put wild type and hyperglycemic type 1 diabetic Akita mice on a high fat, high carbohydrate Western diet for 4 weeks. And then they fed them SGLT2 inhibitor, dapagliflozin, or vehicle for 1 week. And then they performed a variety of metabolomic studies, and they looked at proteins that interact with SGLT2 transporter, etc. And what they found is there's a large variety of proteins that actually interact with SGLT2 and that could potentially be affected by an SGLT2 inhibitor. SGLT2 interacts with membrane transporters that mediate the reabsorption or secretion of sodium, amino acids, urate, proteins, anions, and multiple other compounds. They also found, and this is a volcano plot of the proteomic analysis of the kidney cortex, and in blue are proteins that are downregulated by SGLT2 inhibition, and in red are those proteins that are upregulated. So looking at just some of the proteins that are upregulated by SGLT2 inhibition, you have proteins involved in protein processing, vesicular trafficking, nuclear transport, as well as enzymatic processing of proteins. Looking at proteins that are downregulated include proteins involved in enzymatic, regulatory, and structural purposes. In addition, when you look at, there's profound changes caused by SGLT2 inhibitors by the metabolome. And when you look at the different tissues, you see a large number of changes. You see, in general, in both wild type and Akita mice with SGLT2 inhibitors, you see a decrease in lipids, an increase in ketones, and an increase in free fatty acids. What is not clear whether the loss of glucose in the urine is responsible for all these changes, or is it the effect of SGLT2 inhibition on proteins that interact with SGLT2? But in any case, SGLT2 inhibitors affect metabolism, and affecting metabolism actually has an effect on inflammation. So let's just switch gears a little bit and talk about inflammation. So a critical component of inflammation are macrophages, and macrophages regulate when inflammation begins, its propagation and its regulation. And under physiologic conditions, the resident tissue-specific M2 macrophages are involved in maintenance of the stability of the microenvironment of organs and tissues. The M2 phenotype is promoted by the IL-4 and IL-13, and M2 macrophages are marked by expressing CD206 and CD204 and secreting IL-10, TGF-beta, VEGF, etc. And they're characterized, and so they secrete anti-inflammatory cytokines and they extracellular remodeling enzymes. The M1 polarized macrophages, known as classically activated macrophages, are activated by the cytokine interferon gamma and LPS, and they're involved in helper T1 response to infection. And M1 macrophages produce pro-inflammatory molecules, including tumor necrosis factor alpha and IL-1, IL-6, IL-12, and IL-23. M1 macrophages are really critical for host protection against viruses and intracellular bacteria during acute infections. But if those things are not present, and you have M1 macrophages, you're producing microbicidal and tumoricidal reagents, such as nitric oxide and reactive oxygen intermediates, and for no reason, and all of these things can cause inflammation. Now, hyperglycemia can lead to an increased production of pro-inflammatory cytokines, and oxidative stress can do it as well, and that can lead all to enhancement of M1 macrophages. So ST2 inhibitors, by decreasing hyperglycemia, could lead to less M1 macrophages. And in fact, when you look at the effects of SGLT2 inhibitors on blood interleukin 6 levels compared to those individuals given placebo, you see a marked reduction in IL-6, consistent with a decrease in activation of M1 macrophages. But this decrease in M1 macrophages may be driven more than just by a reduction in hyperglycemia. So SGLT2 inhibitors, by forcing a loss of glucose in the urine, appear to lead to profound metabolic reprogramming. The calorie loss due to glucosuria mimics a fasting-like state. And just as you'd have in a fasting-like state, a number of signaling molecules are activated, such as AMP kinase and SIRT1, PGC1 alpha, and all of these proteins regulate energy metabolism and mitochondrial biogenesis. So when you have activation of SIRT3, you have an increase in beta oxidation, a decrease in oxidative synthesis, and an increase in ATP synthesis. SGLT2 inhibitors also lead to a shift from using carbohydrates for energy to using fatty acids and ketone bodies, and we saw that in the metabolome. And it actually leads to an increase in ATP levels and exerts protective effects, including mitochondrial biogenesis, dynamics. It enhances autophagy and attenuates oxidative stress. In addition, SGLT2 inhibitors actually lead to inhibition of the mTOR pathway, thereby improving insulin resistance, decreasing cardiac fibrosis, and oxidative stress. So when you think about it, it turns out metabolism plays a critical role in determining whether macrophages polarize into M1 or M2 phenotypes. When you rely heavily on aerobic glycolysis and have a disrupted TCA cycle, which you have under low ATP conditions, you produce M1 macrophages that are pro-inflammatory. When you have an intact TCA cycle and are usually utilizing fatty acids for oxidation, you produce M2 macrophages. So activation of AMP kinase that you get with SGLT2 inhibition would promote M2 macrophages. In addition, the blockage of mTOR that you also get with SGLT2 inhibition would reduce the predilection for the formation of M1 macrophages. So if this is so good, does fasting do the same as SGLT2 inhibition? And what's different about SGLT2 inhibitors is that they selectively lower glucose and insulin without affecting protein intake or other nutrients. So that's very different than what happens in fasting. And fasting affects multiple pathways, but maybe can't sustain the AMP kinase and SIRT1 activation long enough to match the pharmacologic effects that you get with SGLT2 inhibition. And of course, fasting requires behavioral compliance, which is highly variable and often short-lived, whereas SGLT2 inhibitors you can just get by giving a pill. So These anti-inflammatory effects are actually directly reflected in the plaques. And this is a study of plaques collected from non-diabetic and type 2 diabetics undergoing carotid endarterectomy. And what you can see is compared to the non-diabetic patients, the diabetic patients who were never on an SGLT2 inhibitor had higher levels of nitrotyrosine, a marker of increased oxidative stress and inflammation. They had increased levels of tumor necrosis factor, a pro-inflammatory cytokine. They had decreased collagen, and a thick collagen-rich cap is associated with stable plaques. So less collagen would be more fragile plaques. They had higher levels of CD68 and higher levels of MMP9. MMP9 is a biomarker of inflammation and tissue remodeling. What's interesting, when they took those individuals, those diabetic patients who were on an SGLT2, you decreased the nitrotyrosine, you decreased the TNF alpha, you increased the collagen, etc. So the type 2 diabetics taking SGLT2, their plaques more resembled those of the non-diabetics. So there is effect on inflammation that can be seen directly in the plaques. However, there's also evidence that SGLT2 inhibition could be affecting the metabolism in plaques directly. And so these are plaques from never SGLT2 inhibitor users, and they also tended to have lower SIRT6 and SGLT2 lower SIRT6 levels. So here you see that this is a non-diabetic. This is never SGLT2 levels. This is SIRT levels, which are increased in which is increased, and SGLT2 expression is also increased as well. So here you have SGLT2 expression within the plaques, which is being increased in those diabetic patients. If you look at those on SGLT2 inhibition, you see that SGLT2 expression uh, is actually decreased, and SIRT is actually SIRT is actually affected as well, more towards a non-diabetic plaque. So here, the plaques themselves can be affected by SGLT2 use directly. And this is just these metabolic changes. So this was actually a culture of endothelial cells. And so we're taking it out of organism, we're taking it out of the effect of SGLT2 inhibitor use on the metabolism of the whole organism, and we're just studying the endothelial cells. So they took these cultured endothelial cells, and you see that culturing in glucose leads to a decrease in SIRT6 and an increase in SGLT2 expression levels. And when you treat with high glucose and an SGLT2 inhibitor, you increase the SIRT6, so it's closer to the levels seen in the non-glucose exposed endothelial cells, and a decrease in SGLT2. So this is just proof that you have these metabolic changes that are not only occurring at the organism level, but they're also occurring at the cell level, especially endothelial cells. So these metabolic changes are also seen in the heart, and this is a study of dapagliflozin treatment of rats. You see that SGLT2 inhibition significantly lowers glucose and insulin, increases glucagon, and increases non-esterified fatty acids, indicating a shift to lipolysis. It also increases beta hydroxy oxidation indicating a shift towards ketones for energy instead of glucose. And when you give acute dapagliflozin treatment, you'll also see increase of relative rates of myocardial pyruvate activation here, oxidation here, which means that the heart is more effectively converting glucose into energy through aerobic oxidation. Chronic SGLT2 inhibition after MI again leads to an increase in non-esterified fatty acids and an increase in beta hydroxybutyrate used as we saw earlier. So in this study, they wanted to determine whether how much of the effects were just due to blocking SGLT2 inhibitor. And to address this question, Berger and colleagues used a knockout SGLT2 mouse and compared the genetic knockout to SGLT2 to pharmacologic inhibition of SGLT2. And here you see that the genetic knockout as well as the pharmacologic knockout have similar metabolic profiles. So, there you have sort of the similar change in glucose and change in insulins, et cetera. And then they performed the wild type and SGLT2 knockout mice. They performed a myocardial infarction model. And 6 weeks after the infarction, they also treated the wild type mouse with empagliflozin, and they also treated the knockout mouse with empagliflozin. And what you can see is if you look at the wild type mouse, when you treat with empagliflozin, you see an increase in ejection fraction, an increase in global radial strain, and sort of a decrease in wall motion score index, and a decrease in end diastolic volume. But what was interesting is when you treat the global knockouts with empagliflozin, you also saw an increase in ejection fraction. You saw an increase in global radial strain. You saw a decrease in wall motion score index and a decrease in end diastolic volume. So this isn't the only experimental model this was found in. So this is another group that used the knockout model. And if you look at and here they use the knockout model versus wild type versus SGLT2 inhibitor treated wild type mouse. And you can see that the non-esterified fatty acids of the knockout moves in the same direction as SGLT2 inhibition. So, but it's just not to the same extent, but you see the same sort of metabolic changes between them. If you look at SGLT2 inhibition, and this is a wild type mouse, you see that even though the infarction size is the same, that dapagliflozin treatment of this increases the survival rate of a mouse after an MI. And here they just show that there's marked profound decrease in fibrosis genes with the dapagliflozin. When you look at the knockout mouse treated with dapagliflozin or the wild type mouse treated with dapagliflozin, you see there's no change in the infarction area. But there is a benefit. The knockout mouse get a benefit from being treated with dapagliflozin. And here you see here's the wild type mouse, and here's the wild type plus EMPA mouse in the black. So you see an increase in survival benefit. Here's a knockout mouse, and then the knockouts plus dapagliflozin, and they also get a survival benefit. So even though you have a knockout, the dapagliflozin is still giving a benefit to survival after myocardial infarction. And when you look, the DAPA treated SGLT knockout mouse have a similar collagen content to the DAPA treated wild type mouse. So, what are some other mechanisms of SGLT2 mediated benefits? And so let's first start with some off-target effects, and we'll go to the microbiome modulation. And so this is a proposed mechanism that is independent of SGLT2 inhibition. At least some SGLT2 inhibitors have been found in the stool, specifically dapagliflozin. And dapagliflozin treated mice have reduced metabolites of tryptophan and phenylalanine in their stool. In addition, you can add dapagliflozin directly to stool culture, culture it under anaerobic conditions, and this will result in a reduction of indole lactic acid and p-creosol, two uremic toxins. Now, if you look at the structure of some of the SGLT2 inhibitors, dapagliflozin, empagliflozin, they have a phenolic or aromatic moiety similar to p-creosol. And these structural features may allow them to bind to the microbial enzymes that normally act on the intermediates of the p-creosol pathway. And that is the hypothetical or the proposed mechanism by which these SGLT2 inhibitors are affecting the metabolites. So by reducing circulating levels of uremic toxins, p-creosol and p-creosol sulfate, you may lead to lower levels of cellular and tissue stress, inflammation, oxidative injury, growth differentiation, and all of these lead to triggers of the growth differentiation factor F, 15. And elevated growth differentiated factor 15 is linked to activation of inflammatory and cell death pathways. It's also linked to adverse tissue remodeling, progression of disease, and progression of disease states are often associated with worse outcomes when you have elevated GDF15. So by lowering the GDF15, you may reverse some of these. In addition, uremic toxins positively regulate their own kidney excretion by stimulating basolateral organic acid transporters in the proximal tubule. So by reducing circulating levels of uremic toxins, SGLT2 inhibition can lower the activity of these kidney transporters, which can lead to retention of body-derived organic acid transport substrates, including amino acid metabolism-derived compounds, acetylcysteine and L-citrulline, which may have some cardiovascular benefits. In addition, Billing showed that SGLT2 inhibition increases the expression of the PGP, and this is involved in the primary proximal tubule excretion of xenobiotics and toxins. And so by upregulating PGP, and you may prevent the accumulation of harmful substances that can lead to cellular damage and organ dysfunction and disease. So that by the effect of the microbiome, you may be having profound systemic effects. You also have an effect on NHE3. So NHE3 is a protein that facilitates the exchange of sodium and hydrogen ions, and thus it plays a role in sodium reabsorption and pH regulation. It's primarily expressed on the apical membrane of epithelial cells of the proximal tubule of the kidney, but it also is expressed in the small intestine. And if you look at opossum kidney cells, which is a proximal tubule cell line, and look at the intracellular pH recovery in response to an acid load and different treatments, you see that S3226, which is a potent and selective inhibitor of the sodium hydrogen exchange, it prevents the acidification. So here we see control. Here you see the sodium free, and here in green, you see that you prevent the acidification that happens with control. Well, it just so happens, if you look at this, the canagliflozin inhibits the acidification as much as S3226. Now, empagliflozin might inhibit early, but does not inhibit late. And now what they did is they took this a step forward, and to show that this was not dependent on SGLT2 inhibition, they looked at rat medullary collecting duct cells that don't express SGLT2, and then they transfected them with a cDNA for NHE3. When they treat with EIPA, which is an inhibitor of NHE3, you see that here is just the pH when you transfect with NHE3, you see an increase in pH over time. When you block this with EAPA, which is the brown here, you block this alkalization. When you treat with the drug, when you treat with the drug canagliflozin here, you see that you block the acidification as much as you do with EAPA. And thus, this is not dependent on SGLT2 because these cells don't have SGLT2. So I think this is really interesting. So this is a direct effect on NHE3. So the last two mechanisms were SGLT2 independent. This uricose-uric effects appears to be SGLT2 dependent mechanism. And so canagliflozin leads to an increase in GLUT9, a uric acid transporter at the mRNA level. So here you can see that GLUT9 is increased with treatment with canagliflozin. But in the GLUT9 knockout, canagliflozin still led to an increase in fractional excretion of urate and reduction in plasma urate. So it wasn't just dependent on the GLUT9, there's other mechanisms at play here. And then when you have a urate knockout, you block the ability of canagliflozin to increase the fractional excretion of urate. And so this is a urate 1 dependent mechanism. And when you sample enough patients on an SGLT2 inhibitor, you see a decrease in serum uric acid with SGLT2 inhibitor treatment, but that effect is small, and it's somewhere between 0.6 with canagliflozin to 0.8 with empagliflozin. But when we think clinically, lowering uric acid by less than 1 mg per deciliter hasn't really led to clinically meaningful benefit for kidney or heart cardiac survival and CKD benefits. So it's unclear whether the uricose-uric effect has some benefit or how big a role it plays in the benefit of SGLT2 inhibitors. So the take-home messages is the loss of glucose with sodium leads to a decrease in intraglomerular pressure. The loss of glucose without increasing insulin causes profound metabolic changes. These metabolic changes contribute to a decrease in inflammation. SGLT2 knockouts do not fully recapitulate the effects of an SGLT2 inhibitor, and the off-target effects of SGLT2 inhibitors affects the microbiome, uric acid, and the transport of toxins in the kidney. So we started down the journey of SGLT2 inhibition to minimize the off-target effects. But it turns out the off-target effects may provide the part of the mechanism for some of the renal protection and cardiac protection offered by these drugs. So I think this reinforces the need to always be humble in medicine because so often we think we know what we are doing or why something works, and our assumptions are proven to be wrong. So with that, I'll end, and I think I ended on time. So I'll be happy to take any questions. There are any.
Can I ask
That's
a question,
great.
Dr. Segal?
Sure.
Sorry, Dr. Kazuri, to interrupt.
Go ahead. I just
Oh,
wanted
okay.
to thank him. You can go ahead on with the questions.
Dr. Segal, that was a great lecture. I mean, I learned so much, and it was really amazing to see the knockout model having the benefit. So that was very surprising and new for me. So my question was about effect on glucagon. So I know you mentioned briefly that it has ability to have a fasting-like status without increasing insulin, and there is change in insulin-glucagon ratio. And I think there was some evidence to show that there is inhibition of SGLT2 on the pancreatic alpha cells, and that can help increase the glucagon level. How about any beneficial effects secondary to glucagon? Has it been tested? Like when you have a glucagon receptor in a knockout model and see the effects are gone or something like that, secondary effect. Is there
Yeah,
any?
so I don't think that has specifically been studied yet, but I didn't specifically search for that. So I'm not saying I know. It may have been done, but I didn't come across it. So that's an interesting question, that effect. Yes.
Thank you.
Perfect. Dr. Ali, I see your camera is on. Do you have a question?
Yes, I do. So, Dr. Segal, very informative and thorough, very nice presentation. Based on your last comment about the off-target effects of DAPA, we have now published on DAPA inhibiting NCC, and this year at the SSWKC meeting, working in collaboration with Dr. Andrew Chandrasekhar, we're going to be showing that it also inhibits NKCC2 in a thick ascending limb. But what are your thoughts about DAPA inhibiting sodium retention and normalizing blood pressure in the kidney? There seems to be an emerging wealth of evidence to show that it has, beneficial off-target effects outside of the proximal tubule.
Yeah, now, and I think that, the interesting thing about this is the number of proteins that are affected with all of this. And whether they are direct or indirect effects, I think it's going to take a lot more research. And whether within downstream on the kidneys, whether that's indirect because of the direct effects on the proximal tubule or not, is a whole other. So I think this the reason I picked this topic is I thought it was pretty clear cut, and sometimes you hear presentations how clear cut the mechanism is, but these are amazing drugs, and I don't think we fully understand all that they are doing, and it was just serendipity that they are as good as they are. And what's really interesting in this is I think there was someone in University of South Florida who actually thought that by his mechanism, these would be detrimental. And, by the direct increasing the sodium delivery to the macula densa effect. He gave a nice presentation on it, but I think what has happened is you have these overwhelming other mechanisms involved, and the overwhelming change in the metabolism due to that loss of glucose is just so profound that it's just the effect of the sodium itself on this on affecting the macula densa may be overwhelmed by all these other mechanisms. So I think your work is really important to try to isolate it. I don't know if you looked at Billings' work to see if your proteins were direct or affected, but I think that would be a really great resource for you.
Thank you.
Perfect. Are there any other questions? Perfect. If there are no other questions, thanks a lot, Dr. Segal, for an excellent presentation. everyone. I hope you'll have a great weekend. We'll see each other next week. Thank you.
Thank you.